Good morning. I am Dr. Sahana, Assistant Professor in Department of Respiratory Medicine. So today we are going to discuss about bronchial asthma. So competencies and specific learning objectives in bronchial asthma are definition, risk factors and triggers, pathogenesis, asthma phenotypes, and we're going to discuss about the symptoms of asthma, investigations in asthma, and management of asthma. So what is asthma? Definition of asthma is it is a heterogeneous disease usually characterized by chronic inflammation. So by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough. And this varies over time and in intensity together with variable expiratory airflow limitation. So risk factors and triggers for asthma. We have endogenous factors, environmental factors and triggers. Endogenous factors are atopy, airway hyperresponsiveness, ethnicity, gender and genetic predisposition. The environmental factors include allergens, which is indoor or it could be outdoor as well, which includes fungi and pollens. And also obesity, occupational sensitizers, parasitic infections, respiratory infections, which is early childhood or viral, and socioeconomic status. Poor socioeconomic status have more predisposition to asthma, and also we have tobacco smoking, which is active and passive. Then we have the triggers. In triggers, it includes allergens, especially house dust mite, animal dander, cockroach, indoor fungi, perennial allergens and seasonal pollens. Then we have the changes in the weather, which is cold air and thunderstorms. So seasonal variation where the people having more exposure during the rainy season and winter season have predisposition to asthma. And also drugs like angiotensin converting enzyme inhibitors, aspirin, beta blockers, NSAIDs, and exercise and hyperventilation, extreme emotional expression like laughing, stress, then irritants which include household sprays, paint fumes and respiratory infections, and even sulfur dioxide and pollutant gases, tobacco smoking, all are triggers for asthma. So coming to the pathophysiology, we have the allergen which goes and binds to the cells, macrophages or dendritic cells, and this stimulates the Th2 cells, and also eosinophil level increases, and this causes mucus hypersecretion or hyperplasia and the vasodilatation on new vessels, which is known as angiogenesis, and there will be bronchoconstriction, hypertrophy, hyperplasia, and also there will be subepithelial fibrosis. So, the genes predisposing to allergies and lack of early Th1 stimulation leads to increase in Th2 expression, and this causes increase in the levels of interleukin 4 and interleukin 13. This activates the B cell and the allergen goes and binds to the Ig antibody in the mast cell, and this activation and mediator release of histamine, leukotrienes and cytokines causes physiological effects such as chronic inflammation and tissue remodeling, and also hyperactive response such as bronchospasm, edema and airway obstruction. So these are all mainly due to the triggers such as allergens, viruses, cold, irritants and exercise. So coming to the asthma phenotypes, we have different types of asthma. Mainly it includes allergic asthma and non-allergic asthma. Then we have the adult onset asthma and asthma with persistent airflow limitation and asthma with obesity. So what are the symptoms of asthma? So in patients with history of shortness of breath, cough, chest tightness, and wheeze, we should always rule out bronchial asthma. So these symptoms, they're often worse at night and in early morning. And this is called as diurnal variation, where the symptoms are more present in the night. So patient will have cough and chest tightness or shortness of breath more in the night and early morning. And this varies over time and in intensity. And if you ask in detail about the patient history, they will tell that they'll be triggered by any exercise or allergen exposure or viral infection or any changes in weather, and also stress, laughter, or other irritants. So coming to the investigations, how do we know whether patient has bronchial asthma or not? So first, we do lung function test. In lung function test, there will be reduced FEV1 and reduced FEV1 by FEC ratio. So compared to the lower limit of normal, if it is reduced, then we can tell that patient has bronchial asthma by doing bronchodilator reversibility test. So if it is a positive bronchodilator reversibility test in adults, there will be increase in FEV1 of more than 12% and 200 ml. Whereas in children, there will be increase in FEV1 of more than 12% predicted. And also excessive variability in twice daily peak expected flow rate over 2 weeks. And that in adults, there will be average daily diurnal PEF variability of more than 10%, whereas in children, there will be average daily diurnal PEF variability of more than 13%. So other tests for concluding that the patient has bronchial asthma, we have bronchial provocation test, allergy test, FeNO. Then we have the blood investigations like absolute eosinophil count and serum Ig levels we check. And then we have skin prick testing, then sputum examination. So different types of asthma also we can, based on history, we can classify them as asthma and aspirin sensitivity, occupational asthma, then work exacerbated asthma, and exercise induced asthma. So coming to the treatment, we have pharmacological therapy and non-pharmacological therapy. So pharmacological therapy includes bronchodilators, corticosteroids, biologics in asthma, immunotherapy, vaccination, bronchial thermoplasty, and vitamin D. So what are the inhalational devices we know which we give for bronchial asthma? So inhalational devices are the devices which deliver the drug at the site of action, and lower doses required and systemic side effects are minimized. So there are 4 classes of anti-asthma drug, which includes beta-2 agonist, anticholinergics, chromoglycate, and glucocorticoids. These are available for inhalational use. Efficacy of aerosolized drug depends on the particle size, which is 1 to 5 micrometer diameter, and these particles deposit on the bronchioles and effectively deliver the drug. So we can use only inhalers or nebulizations for localized site of action, and they have very less systemic side effects. So inhalation devices are preferred for bronchial asthma treatment. So then we have the aerosols, which are of 2 types. So we have MDA, which is metered dose inhaler, and nebulizer. In this, the drug will be in solution, whereas we have used drugs in powder also, which includes DPI, that is dry powdered inhaler. In this, we have spinhaler and rotahaler types. So this is the picture of inhalational drug delivery systems, which first image is the metered dose inhaler, where you can take in form of puffs, and then we have spacer. So with spacer, MDA will be attached to the spacer, and the patient can take it in the form of metered dose inhaler. Then we have the rotahaler, which we use for dry powder inhaler. So we put the capsule and break it in the powder form, and then we inhale it in the rotahaler. Then we have the nebulizer form, where the solution respule is poured, and then the patient inhales a mask, nebulization mask. Then we have the non-pharmacological therapy. So the non-pharmacological therapy includes cessation of smoking and environmental tobacco smoking exposure. So first step is to stop smoking in non-pharmacological therapy if the patient is smoker or has history of smoking. Then second is to encourage a patient to have some physical activity like walking, minimal exercises, and every day patient can also do breathing exercises like pranayama, deep breathing exercises. Then you should advise the patient to always avoid any occupational exposure if it is present in their occupational area. So history is very important, where if patient is having any occupational exposure, we have to ask them to avoid those kind of occupational exposure. Then also, if any trigger factors are there like outdoor pollutants or indoor pollutants, we ask the patient to avoid the triggering factors. So avoidance of other triggering factors also an important non-pharmacological therapy. Then we have lifestyle modification. So lifestyle modification mainly includes to loss of weight and to maintain a healthy BMI, and also breathing exercises and minimal exercises every day. So this also includes diet habits, and where they have to avoid all kind of cold items or any other milk products or dairy products which are allergic to them, and also encourage breathing exercises. So coming to the selecting initial control treatment in adults and adolescents with a diagnosis of asthma, we have like in adults and adolescents of 12 years with a diagnosis of asthma, first we have to assess. So if confirmation of diagnosis is there, daily like symptoms are walking at night once a week or more, and if they have low lung function, then we start with medium dose ICS, formoterol maintenance and reliever. Or we can give medium or high dose ICS LABA and as needed SABA. So this is a step 4, where there is short course oral corticosteroid may also be needed for patients presenting with severely uncontrolled asthma. Then we have symptom control and modifiable risk factors, which includes lung function. So if patient has symptoms most days or waking at night once a week or more, if this is there, then we have to start on low dose ICS, formoterol maintenance and reliever. And another alternative is low dose ICS LABA and as needed SABA. Then we have to check for comorbidities and inhaler technique and adherence, then patient preferences and goals. So all these we have to assess. So if the symptoms are there twice a month or more, then we go for as needed low dose ICS formoterol. Then alternative is low dose ICS plus as needed SABA. So this is step 2. Then if these symptoms are not there twice a month or more, we go for as needed low dose ICS formoterol, and alternative is you have to take low dose ICS whenever SABA is taken. So this is step 1. So mainly it can start from step 1 and then it goes to step 4 if there are daily symptoms, waking up at night once a week or more, and if there is low lung function. So in adults and adolescents 12 plus years, we have personalized asthma management, which includes assess, adjust, review for individual patient needs. So in assess, we have confirmation of diagnosis if necessary, symptom control and modifiable risk factors, and comorbidities, inhaler technique and adherence, patient preference and goals. All these we have to assess. And in adjusting, we have the treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, asthma medications, which adjust down, up, or between tracks, education and skills training. Then in review, we have symptoms, exacerbations, side effects, lung function, patient satisfaction. So the controller and preferred reliever using ICS formoterol as reliever reduces the risk of exacerbations compared with using a SABA reliever. So step 1 to 2 includes as needed low dose ICS formoterol. Then step 3 includes low dose maintenance ICS formoterol. Whereas step 4 it is medium dose maintenance ICS formoterol. And in step 5 it is add-on LAMA, that is long acting muscarinic agonist, refer for assessment of phenotype. And we have to consider high dose maintenance ICS formoterol with or without anti-IgE, anti-IL-5 or 5R, anti-IL-4R and anti-TSLP. So this is reliever we can use as needed low dose ICS formoterol. Then we have the controller and alternative reliever. So before considering a regimen with SABA reliever, you have to check if the patient is likely to be adherent with daily controller. So step 1, you have to take ICS whenever SABA is taken, and in step 2, low dose maintenance ICS, and in step 3, low dose maintenance ICS LABA, and in step 4, medium or high dose maintenance ICS LABA. Then in step 5, we give add-on LAMA, which refer for assessment of phenotype. Consider high-dose maintenance ICS LABA plus or minus anti-IgE, then anti-IL-5 or 5R, and anti-IL-4R, anti-TSLP. So other controller options for either track limited indications or less evidence for efficacy or safety. We can go for step 1, step 2, where there is low dose ICS whenever SABA is taken, or daily leukotriene receptor antagonist, or we can give HTM slit. Slit is sublingual immunotherapy. Then in step 3, you can give other option as medium dose ICS, or you can add leukotriene receptor antagonist, or we can give sublingual immunotherapy. Then in step 4, we can give another option as add, you have to LAMA add, or LTRA, that is leukotriene receptor antagonist, or we can give sublingual immunotherapy, or switch to high dose ICS. Then in step 5, other option could be we can add azithromycin or leukotriene receptor antagonist, and as last resort we have to consider adding low dose oral corticosteroid, but we have to consider other side effects. So in oral corticosteroid, if you keep on using oral corticosteroid for long term, then there could be many side effects such as peptic ulcer, cataract, glaucoma, and also we can have osteoporosis, and many other complication side effects are there for oral corticosteroid. So it is always preferred to use it in the last step. So the complications for asthma include status asthmaticus, respiratory failure, pneumonia, and atelectasis. Thank you. So complications in asthma are status asthmaticus, respiratory failure. In asthma, most common type of respiratory failure is type 1 respiratory failure, where SpO2 will be less than 85%, and also in PaO2 in ABG will be less than 55. And the most common complication in asthma is pneumonia and atelectasis. So coming to the summary, in asthma, the most common symptoms where patient presents with this breathlessness, wheezing, chest tightness. And how do we confirm that the patient has asthma or not is by doing spirometry. So in spirometry, we'll check for reversibility, and also in X-ray there might be some bronchovascular markings, or it can be normal also. And also we can treat asthma mainly by bronchodilators, and then we can give inhalational corticosteroids. So bronchodilators can be given in form of meter dose inhaler or dry powdered inhaler and nebulizers. And the non-pharmacological treatment for asthma is by doing breathing exercises, and if patient has any smoking history or if any other substance abuse is there, to stop using the smoking substances or any other substance. And also doing pulmonary rehabilitation and vaccination to prevent any other infection. Thank you.
you.